Hello, everyone. Welcome to Hot Seat. Once again, so happy to be with you all from this educational platform. And we have a very special guest today. Finally, I have the chance to have this great guy, educator from California with us. Ziv Simon is my special guest in this series of Hot Seat. And so happy to have him on the show. Hi, Ziv.
Hey, how are you?
Thank you so much, my friend. You know, over the past sessions, we talked about the importance of hard tissue, soft tissue, the successful key elements in implantology. We talked about complications a little bit. We talked about digital dentistry and how it can have effect on implant dentistry. We talked about prosthetic approaches for maximizing success in the aesthetic zone. And we will talk about also on the same topics in the future too. But today, the topic that Ziv gonna cover for us is one of the things that make a dentist or implant surgeon's job way easier by getting the better concept for simple, safe, and predictable soft tissue grafting around teeth and implant, which I believe every surgeon should know exactly the details about it, because at the end of the day, it's the soft tissue that dictates what should be the result. And I'm so happy that Ziv accepted this invitation and is joining us in this series of Hot Seat. So as a tradition, I will have Ziv's CV for all of you. I'm pretty sure almost all of you, if you are at least on Facebook, know this guy because he's truly one of the people that tries his best to educate dentists around the world. And I'm so happy to say that. And I found a very precious quote in his CV, which I will have for you, that he believes that knowledge should be shared without limits. I love that quote. And I'm so happy again to have him in the program. So Dr. Simon is a practicing periodontist in a private practice in Beverly Hills, California. He has made it his life mission to educate dentists around the world on how to excel in surgery and experiencing growth and fulfillment. His teachings are an open book to how he performs in his private practice and strongly believes that knowledge should be shared without limit. He's been pursuing surgical mastery for the past 20 years. He's the creator of the Surgical Master Teaching Platform, the fastest growing surgical education platform in the world. Once again, I'm so happy to have Ziv on the show. And again, the topic that he will present for us is simple, safe, and predictable soft tissue grafting for teeth and implant. Ziv, we are ready for your amazing presentation. And once again, thank you for accepting this invitation.
Absolutely, Omid. Thank you so much for having me. It's great to finally meet you. It's great to be in the hot seat. And I'm a little bit, hot because I want to share the message about soft tissue grafting. As you know, as a fellow surgeon, soft tissue, in my opinion, is almost more important than the bone. And you can have a great bone grafting procedure and a great augmentation, but if the soft tissue is lacking, the whole case can fall apart. And besides, aesthetics is on the outside, at least in dentistry. So thank you again for having me. And should we just get right to it?
Sure. You're ready.
Beautiful. Thank you again. Excellent. So thank you again. My name is Dr. Ziv Simon. I'm a periodontist. I practice in Beverly Hills, California. Like Omid said, my mission is to educate dentists around the world, wherever they're at, whatever continent, whatever ethnicity, culture, philosophy, it doesn't matter. We all dentists, we all went to dental school, and the goal is to excel and to master what we're doing. And if we just sit at home and we don't expand our skills and we don't push it to the next limit, then life is all about mastery. So personally, I'm humbled by the introduction, but I'm also on the path of growth and mastery for myself, and I always want to learn from other surgeons like my fellow surgeon here from all around the world, and the other distinguished guests that he had in the Hot Seat podcast or webinar series. So I wanted to talk to you about actually something that is relatively simple to do. And if you learn the simple procedures for soft tissue grafting around teeth, you can extrapolate and apply them to implants. And that does not mean that implants are teeth. They're very different, obviously, and we can't utilize the same principles, but you can use some of the surgical techniques in creating better soft tissue contours for your implants. So I'm going to talk about implants, I'm going to talk about teeth. I'll keep it very, very simple, short, and concise, so we can all understand and, more importantly, utilize it in our practices. So our goal is to create great soft tissue around our teeth. We all know the principles of aesthetics, the principles of symmetry, balance, and having great tooth exposure. However, when we have soft tissue deficiency, like recession, that immediately takes away from the aesthetics, whether it's around teeth or implants. And we must know what are the options for treating the natural dentition and what are the success rates for each procedure. And we can look at the literature, but I think the best literature is in your own practice. If you apply the right protocols, if you follow clean, accurate surgical technique, you can be very, very successful. And of course, not forgetting the biology. And they're very, very simple things that you must pay attention to. There are two things that we usually deal with when it comes to implants. We're dealing with soft tissue quantity, like recession, or soft tissue quality, like poor tissue quality, like poor attached and keratinized tissue. And what are the options for that? For example, when we treat a full arch or multiple teeth, the tunneling technique with alloderm or with connective tissue grafting works quite well. And knowing how to do this type of procedure is really based on starting with a single tooth. So my first advice for this lecture is, even if you have the desire to treat a full arch and a full mouth, and you have the surgical skills and you have the hand dexterity, but if you don't have the experience with soft tissue grafting, follow the roadmap. Start with one or two teeth. Start with the simple cases to avoid disappointments by you and by the patient. So focus on building your skills gradually. And this is what I did. And when I failed to do this, I faced some disasters. To treat soft tissue quality is a very predictable thing. It's been around for a long time, using a free gingival graft or the epithelialized palatal graft, harvesting a small piece of tissue from the palate and grafting it around a tooth. It's probably not the most aesthetic outcome, but it certainly does the job. It creates good tissue quality. Sometimes we can even get a little bit of root coverage. And I call it the workhorse. Some of us here call it the send your kids to college procedure. Why? Because it's a very lucrative procedure. It's very simple. It's very predictable. It's safe. And you can do it almost once or twice a week in your practices. And it has the potential to support your kids' education, at least in our community, because we know education for kids is very expensive. So we want you to utilize things that you can do that are beneficial for your patient and make an honest living by treating patients in what they need. And this is one of the examples. But there are so many other procedures out there, from connective tissue grafting to tunneling to sliding flaps, you name it, Vista, pinhole. There are so many things out there. And it's easy to get confused, even for a specialist like myself, specialist like Omid. It's kind of overwhelming sometimes if you see so many different procedures. But if we take it a step back and we try to figure out, okay, what are the keys to success? It's really all about blood supply and a receptive root. We want to get the blood supply to the grafted tissue, and we want to have a root that receives the graft, that is non-restored, non-caries, and non-contaminated. These are the keys. Now, implants are totally different. And I mistakenly thought when I started 20 years ago, if I can do a connective tissue graft around a tooth, hey, what's the difference? Same technique, same procedure. Well, it's a huge difference. There's no receptive root. The tissue and bone around implants is usually not as ideal, at least in those days. And I faced some very big challenges, especially now as we know that implants integrate and the success rates are extremely high. But we're still facing major challenges in terms of the tissue. We're missing tissue height, we're missing tissue volume, and tissue stability are some of the biggest challenges that we currently have. And some of us may say, okay, it's the function of the bone underneath. And that in part is true because we also have limitations about how much bone we can graft. But tissue always remains one of the limiting factors, at least in my opinion, in my experience. And besides, we have so much pressure on us as surgeons and as treating clinicians to make the patient happy. There's really no forgiveness when it comes to the aesthetic zone. It's visible. Even if you lose 10% of the papilla, some of the patients, I'm sure anywhere in the world, will be bothered by it. And even if we got a great result, what happens 5 to 10 years later? Sometimes success is not final. And I'm going to show you some of my own failures in this lecture, because I truly believe that if we don't share our failures, we're not being 100% honest with our audiences and with ourselves, most importantly, okay? Because the truth is always the most powerful thing in the world. Sometimes tissue problems occur because of a surgical error, and I've made enough errors and mistakes in my career and still making them because of wrong placement, because of errors in surgical technique. Sometimes it is a restorative error, and sometimes it's a combination, and they're not, some are unavoidable, some are avoidable, and we all have those. So the best predictor for success in the aesthetic zone when it comes to implants is not the implant, it's the adjacent teeth. And that's something that took me a few years to get. If you have a single missing central incisor, and even if the site is deficient and there's no buccal plate, if the adjacent teeth are powerful and strong and have attachment, you got a great chance. Once you start losing the attachment on the adjacent teeth, they start to develop periodontal problems, mobility, problems of their own. The success rate from an aesthetic point of view goes down, and we can get an implant to integrate, but the question is, how is it going to look like? So my second advice for this lecture is, before you even start an aesthetic implant, don't just look in the tunnel on the implant, look sideways, look at the teeth adjacent and see what's their condition, and you can save yourself a lot of trouble. And I wish I gave myself this advice, 20 years ago. Ultimately, buccal plate is extremely important as well. It's the challenge we had. I feel like I've been talking about the buccal plate for 20 years, and I think I'll talk about it for the next 20 years because it's a tiny little structure that is less than a millimeter, very often not even visible on a CT scan. And if it's not visible on a CT scan, it doesn't mean it's not there. We know this for a fact. We extract teeth and we see a buccal plate, but it's paper thin. And this buccal plate it disappears. It doesn't matter if you place an immediate implant, if you grafted it, if you did all sorts of magic and use the best bone graft in the world, it will disappear. Why? Because it's alveolar bone. Alveolar bone is functional bone, and it functions because the tooth is there. It functions and stays there because of the presence of teeth. Once the tooth is gone, the bone is gone. And I talk to patients about it very openly. And my patients, I consider them my friends and my family, most of them, like dentists around the world. And we have to be very open about it. The buccal plate goes away not because you're a bad surgeon or you did something wrong. Of course, you want to be very careful when you extract teeth and use mostly vertical forces and extract the tooth as vertical as you can, meaning without damaging the buccal plate. But the buccal plate is functional. The basal bone stays, and for the most part, and that's something that we utilize many times in the mandible for all-on-4 cases, full mouth cases of implants. We anchor our implants in the basal bone that is very stable for long term. Now, what I personally learned from Dr. Isaac Binderman, one of my professors in Israel, who's a world-renowned scientist and biologist, bone biologist, is that the palatal bone actually behaves like basal bone. So technically, the coronal part of the bone on the palatal aspect actually behaves like basal bone. And what does it mean? It means that it has a better chance to stay, or it stays. And we see this clinically all the time, most of the time. And that's our last hope. Now, if we lose the palatal bone, the situation is usually much more severe. And over the years, I tried everything in the book to preserve, from using a very atraumatic extraction technique, for example, using this Benex device. Of course, when you extract teeth in thick bone and thick tissue, and you go through this implant process, you will get a good result, but there will be some compromise from the beginning. Even if your extraction technique is clean, is atraumatic, is vertical as best as possible, you will get some shrinkage of the papilla. And you can see this right in here. And this is considered a good case, and I would take this case any day. And if all my cases end up being like this, I would definitely sign the contract to have it promised to me. We know there are no promises, and we know that even under the best circumstances, we're going to lose some tissue. And it may take a few years. So please look at your implants, not a month later, not a year later. Look at them 5 to 10 years later. They're not looking the same, okay? So we gotta be honest with ourselves. So we have some shrinkage of the tissue. And we accept it. We accept acceptable results. I constantly try to improve myself and master my own techniques and learn from other doctors and other mentors. But sometimes we need to know this is kind of the best we can get. And I'm going to talk about it. So communication with your patient is extremely critical. And the way I communicate with patients is similar to how I talk to you right now. I hope I'm very clear, very simple to understand. And I want to do it also in a concise way. I don't like to fluff and talk, just beat around the bush. I want to make sure that everybody understands. So when I talk to my patient, I tell them in a very simple way. When a tooth is lost, the bone starts to resorb, to melt away. We can minimize it. We cannot prevent it. If it happens, the tooth will look longer. Sometimes the tissue between the teeth can also shrink. So if you are now watching this presentation, and if you can pick up only one thing, that's the thing, the communication with the patient. It doesn't have to be scientific. It doesn't have to be complicated. Keep it very simple. Tell your patient the exact 4 points, hit all of them. Don't be scared the patient's gonna run away. If they run away, it's probably a good thing. Mm-hmm. They're not gonna run away because you're transparent and you're honest. And some of my patients tell me, but no, it's not gonna happen because we came to you, we thought you were the best, you're a specialist. And I say, no, this has nothing to do with me. This is the law of nature. You cannot be more powerful than nature. And this is what's happening. We have some ways to minimize it, but it will happen. So I always want to put it up front and set myself up for success in terms of the patient expectations. Now, sometimes the tissue is thick, but the bone is thin. And I thought, maybe if we do more immediate loading and, use very care in terms of placing an immediate implant and an immediate provisional and doing some preventative grafting, what we call grafting the gap that you've heard about before, is that going to help? Yes, it does help, no doubt about it, compared to not doing it. But remember, the law of nature is much stronger than you as a doctor. You as a doctor, as a surgeon, you're not God. I have to tell you the news, some doctors forget about it. We're not God. We are trying the best that we can to emulate nature and give the patients the best possible today. Success is not always final. Very often you will see years later, even if the patient doesn't notice, even if the lip line is low, your patients will notice, or you will notice some darkening of the tissue. Why is it dark? It's darkening because the buccal plate slowly starts to resorb. Maybe the bone graft starts to resorb. And that is a challenge, especially in a high smile line. I'm going to take it to the extreme. No bone, no tissue. You need to know augmentations. You need to, even if you mastered guided surgery and you are really good with your hands and you can do great things, you still need to know basic surgical principles trying to augment the bone, because very often, and this is a trauma case, there's not a whole lot of bone to work with. And there are different techniques. I'm not going to get into that, but use the most conservative technique that you can. And we can argue and talk and debate academically as colleagues and as friends, what is the best way to do it? And what's the most permanent augmentation that we can provide? But ultimately, we're going to get some shrinkage with most types of bone grafts, not because the augmentation was not great. It's because the structure we're implanting in the bone is not a tooth, it's an implant. And we have to kind of make a switch and know the limitations of us as, let's call ourselves human. And this is all we can do. And we will get better at it. So here's just a case of an augmentation and a delayed placement. Every time you have a huge defect, you want to delay the placement and place the implants accurately and get a great result. But again, remember that the success of this result, this case, is not so much because what I did, it's mostly because of the adjacent teeth that have great tissue and great attachment. And this is why I got the papilla. And it helps to place the implant at the right depth, at the right position. Obviously, that's a good thing. So success is not final. I always like to bring my patients back, even if they have no symptoms. Let me check, let me take some x-rays. They appreciate it. They don't know what I want from them, but I have a great relationship with my patients. So they do it, and I don't charge them for the follow-ups. You will see years later, you'll start seeing some thinning. The patient is ecstatic. They think you are God. You're not God, but they think you are God. And you'll start seeing some thinning up of the tissue. It's a problem. So let's go back a little bit. Now that you kind of understand my philosophy, I feel that before you get into tissue grafting around implants, and I'm going to show you some socket shields and rotated palatal flaps and fun things that may look complex to some of you. And some of you are doing this already, and that's wonderful. All these skills are actually not difficult. Technically, they're not difficult. You're a dentist trained in dental school. Dental school prepares you for your hand dexterity, your manual skills. You got them. If you can prep a tooth for a crown, for an onlay, whatever it may be, for veneers, you have the skills, the manual skills to do surgery. In surgery, it's more about decision-making, understanding the biology of healing, where to make the incisions, and of course, we have different options, what type of flaps, how to manipulate the flap, and suturing. And again, suturing is not a difficult thing. Suturing is about just understanding how, the principles of suturing. The manual skills of how we tie knots is not that difficult. It's practice, obviously, but it's not difficult. It's more the decision, how to place the suture and where. And that's just a fun thing to go through. So my advice to you, before you start pedicle flaps and free grafts around implants and mobilizing tissue coronally, start with basic periodontal procedures. And I'm putting out a slide of just an open flap debridement. Very simple procedure. The patient had a large pocket. I'm not going to get too much into detail. One vertical incision, a full thickness flap, cleaning out the roots, using emdogain or not, whatever it may be. And that's a skill that you want to utilize right away. Your patients have pockets, your patients have periodontal disease. Educate yourself about periodontal treatment, surgical and non-surgical. and start there. That's the safest. That's where the patients need it. And you can also gain some surgical skills in the process. Now, as you start performing more periodontal procedures, you'll start noticing mucogingival problems, like what you see here on the lower canine. You see an area that is maybe has some attachment, but it has no keratinization. You see those blood vessels are climbing all the way on top, all the way to the gingival margin. And this is an area that is not stable. It will regress periodontally. And I personally, for these types of situations, I recommend, especially if it's a non-visible area, I recommend a free gingival graft. So the way we do it, I make an incision at the mucogingival junction, and I can potentially make a little bit of annotations in here. So if I identify the mucogingival junction around here, I will then take a number 15 blade, make the incision right at the junction, and displace the flap in a coronal direction. I lost my mouse here. And then, let me see. Clear the annotations here. Great, sorry about that. So, and then we'll displace the flap apically, suture it, deepithelialize the remaining attached tissue. And then once the recipient site is ready, I'm going to harvest a small piece of a free gingival graft, which is the epithelial component. Usually I start with a rectangular shape from the flat part of the palate, staying away from the rugae, staying away from the soft palate, obviously, staying away from the free gingival margin. And in a very careful dissection, I then take this graft and suture it to the recipient site. And the results for this type of graft, I have to say, they're up to 99%. Not all my cases are successful. I had cases that failed miserably, and I had sloughing of grafts, but in a very, very small percentage. So if you want to start with soft tissue grafting, this is the type of graft that you want to start with. And you can tell that there's a large increase of the attached and keratinized tissue, the tissue thickness, and we know this is much healthier. And it's a very simple procedure to perform. Can we take this graft and now develop it around implants? Can we do this around an implant? Well, it's better to do it before you place the implant. So you can utilize the exact same technique before you place your implant, assuming the bone is adequate. And if you think about it, the graft itself doesn't care about teeth or implants. The graft itself only cares about blood supply. And the blood supply is very easy to retain. If you follow the mucogingival junction that is now above the ridge, all you need to do is follow with a number 15 blade while you pull the tissue away and create a split thickness flap, stabilize it, and add a free gingival graft. It's a simple thing to do. It's a valuable thing. And long-term, once you place your implant, once your graft heals, you will be able to have an implant restored in good tissue quantity and quality. And we know that these implants are much more stable compared to the ones that have only mucosa around them, because very often we have great implants and great bone, but what happens then, the tissue starts to retract because it's only mucosa, especially in the posterior mandible. This is where we see most of our problems. And this is just a great thing to have, a simple skill that works up to 99% success rates. Why? Because there's great blood supply and gives you what you want. Okay, so this is something that I recommend to every dentist. Start periodontal treatment, surgical and non-surgical, start incorporating free gingival grafts. Do maybe 5 to 10 of those, get comfortable with the technique, get comfortable with the harvesting and the suturing, then transition to implant sites, which is going to be a great advantage to you. So going back to our careful extraction in our quest to preserve the buccal plate, we said tissue quality is one of them, and you just learned one procedure that can help. This type of procedure is not the most aesthetic in the aesthetic zone, we don't do it. We have some other ways because it does leave maybe a patchy appearance, sometimes scar tissue. In the aesthetic zone, we work a little bit differently. So in the aesthetic zone, of course, we have traumatic injuries of teeth. We focus on the proper extraction technique as best as possible. This is a Benex extractor. It allows me to engage the root and extract it very carefully and slowly out of the socket. And that again is a great thing to have in your practice. The investment is not very large, but if you use it once a month, twice a month, you got your investment returned already. So in this case, I used what we call a dentin graft. I took the root, I ground it up, and I made dentin graft out of it, and then placed it in the socket. So this graft is technically not a bone graft. It's made out of dentin and cementum. It's pulverized to a very small particle size. There are more and more studies talking about how these grafts work. I'm not going to get too much into the biology, but just in essence, most bone grafts heal via encapsulation. This type of bone graft heals via direct apposition of bone, similar to what happens when a tooth gets avulsed and reimplanted, the bone ankyloses to it, and that creates a whole other set of problems. But this type of graft in the particles creates a very nice substantial augmentation of the socket. And you can see the fast healing. This is about 3 weeks of healing, very, very quick and great tissue. And patient is ready sooner for the implant placement. And well, even with dentin grafting, it does not affect the buccal plate. And again, I would take this result, no problem. I would take it every day, sign me up. But the buccal plate doesn't even think about dentin. It just resorbs because it doesn't have the stimulation, the blood supply from the PDL. That's gone when the tooth is gone. You have to remember that. Okay, so you will have the shrinkage. Now, sometimes we can do our due diligence with the prosthetics and maybe spend more time molding the tissue, training the tissue, maybe grafting at the same time. Some surgeons graft routinely at the same time. I feel it's a great option. I don't feel it's a guarantee to have good tissue. Every patient would be different. So the buccal plate is the one that goes. And this is, I believe, why close to 20 years ago, the socket shield was introduced to the market. The socket shield in the current version, not retained roots. Retained roots have been in the literature and in dentistry for a long time. The idea is obviously to retain part of the root facing the buccal plate. So from the buccal plate point of view, which we see here in the cross-section on the CT scan, if we just leave part of the root, as far as the buccal plate is concerned, the tooth is there. So our thinking is it's going to stay there. And that's what we're seeing. And right now, socket shielding is the most promising technique and the one that gives us the best results. What will grows and the implants stay ankylosed? What will happen long-term to the shield is very hard to tell. My longest follow-up on socket shielding is several years. I mean, I've been doing now for about maybe 5-6 years socket shielding. Slowly, gradually, it's a little bit more of a challenging technique. I think the instrumentations are critical. Instrumentation is critical. So look into the long burrs that need to be done and also know the steps. So I'm going to share this with you. So the idea is to place the implant more palatal, away from the shield to preserve it. And this is what was termed as the socket shield technique, or root membrane. That there are different names to it. Again, published in 2010, 10 years ago, but it's been around. It's been around before. We have some histology. It basically has 3 simple steps. Maybe not so simple, but 3 steps. The first step is the mesiodistal sectioning, or the splitting. And this is where you need to use a long burr and split the root mesiodistally all the way to the apex, and actually beyond the apex if you can. Second is to remove the palatal component of the root. Personally, this is where I'm challenging myself the most, because if my split is not all the way through, I'm not right in the middle of the tooth, then sometimes those the palatal root comes out in pieces and I can't really see. That's the challenge that I have. Step number 3 is adjusting the shield. And how do we adjust it? We level it at bone. We thin it out to about 1 millimeter of thickness as best as possible, and we create a tiny little bevel to allow for some restorative freedom. And that's more or less how it looks like. I'm going to share with you some of the mistakes that I've made. So here are the three things we need to do. 1 millimeter thickness, place it at bone level, and place a little bevel. And I personally don't place immediate implants with socket shielding. I delay my placement and I wait for the tissue to heal. I wait for the bone to mature. I take another CT scan, and it's a beautiful thing to see the shield in the socket. It's like a report card. You see how you performed after the fact 2-3 months later. And sometimes it's not ideal. Sometimes you see that like in this case, I went through part of the buccal plate and the apical part, but the coronal part of the plate stayed. So you get an immediate feedback on how you did the socket shield, which is a great thing. And sometimes it looks better than what I thought it would look like. So both things. Then I plan my implants. I like to keep it 1 millimeter away from the shield. I know that some studies showed that it's not needed. I feel that in the guided approach, you can plan for it to be away from the shield, and that's my preference. And then the placement. According to the placement rules did not change based on the shield in terms of the 3-dimensional positioning. And sometimes we even keep part of the shield mesial and distal to support the papilla. Does it happen intentionally? I'd like to say yes, but sometimes it's hard to do. So especially if you're using a flapless approach. So the requirements for a socket shield to work is number 1, no mobility. I strongly recommend use a CT scan and use very, very long burrs, ideally dedicated burrs. There are a couple of kits out on the market that you can look up. And take your time. Don't rush. Study where the tooth is positioned so you can position your hand appropriately. Use magnification. Make sure that you're seeing what you're doing, illumination. You need to make sure that before you decide on a socket shield, that the buccal plate is there. If the buccal plate is not there to begin with, there's nothing to shield. There's nothing to shield. So I want you to get into a thinking mindset. The thinking dentist is a very important place to be in. Don't just be a technician. There's enough technicians in the world. You're getting paid well to think and to recommend the right thing, not to be like a technician. So assess the site before, make sure the tooth is not mobile, make sure that there's a buccal plate that you need to preserve, and then a socket shield is a good thing to do. For example, in this case, the patient was missing the whole buccal plate to begin with. There's nothing to shield, we take out the whole tooth. Is it okay to engage the shield? I mentioned before, I don't. There are some studies coming out now where the shield is engaged with the implant. So if you think about it, as you prep for your implant, there's always a gap between the preparation between the osteotomy and the implant. And that is very visible right in here. So you can see the bone growing all around the thread of the implant into the dentin of the socket shield. So you could, and some do. I personally don't, because I feel like I want to have my implant fully in bone. Should we do it as an immediate or delayed? It doesn't affect the success rates. That we know already from, regardless of socket shielding. I personally like to delay it. I have a couple of immediate cases like this one, but I always pre-plan them. So I plan them in bone. We have adequate bone in here. I make sure that the implant is deep enough, and I place it away from the shield, planning the shield already in my mind and in my preparation. And as I completed the shield, then I place the implant and graft the gap. at the same time because I place it a little bit away from it. Should you do it immediate or delayed? Well, if you have to ask the question, then do it delayed. If you have to ask this question, do it delayed because it'll be safer. You'll separate the two procedures, make sure that one works first, and then you have ample bone to place your implant. It does not affect the success rates. The concern that I have, if you're doing this more freehand, which is a possibility, or you're doing this more in a conventional guidance, you won't have 100% control over the placement. But certainly the socket shield is something that is so impressive to us in implant dentistry to see the preservation of bone. Now, any problems? Like we say here, are you kidding me? Of course, we always have problems with anything we do. Actually, now that we include socket shielding, we have a whole new list of problems that happen just due to socket shielding. So I'm going to share only, I think, 2 or 3 in this presentation. So new complications. The new complications can come from the mesiodistal split, not being able to split it all the way through, not being able to split it all the way apically, the palatal removal, the adjustment. All of these create some problems, and I wanted to share my own problems. So these are technical problems that can be resolved. Here's one of them: patient with root resorption adjacent to a lateral tooth was cracked. So I did the socket shield, but in the process, I did not have full control over my long burr, and it went through the mesial aspect of the buccal plate. And then I had to reflect the flap. I had to see what the damage is like. I had to then adjust the shield, do almost like a little apico, but I focused on keeping the part that was more coronal, because that's what's going to save us. That's what's going to save the buccal plate. And then I treated it like a defect with a membrane, with, in this case, a PRF membrane, and suturing. So it's actually a simple defect to repair. If regardless, it's induced by me, meaning caused by me, but it's simple to repair. And you can see that the healing, and you can see it on the scan. You can see the ample bone. You can see signs of the shield right on the buccal, not to the full extent, but it's there, and it's protecting us. It's shielding the socket. It's shielding the site from resorption. So the shield must be at bone level. This is one of the criteria. Now I thought to myself, you know what? I know all the greats, they're recommending it at bone level. I don't think so. I think that, in this case, for example, if I bring the shield down all the way to bone level, won't I get the collapse of the component that has epithelial attachment and connective tissue attachment? That's, if you know about the periodontal attachment. I'm going to leave it at the connective tissue attachment, suprabone, and maybe I'll get a better result. And obviously, this tooth is hopeless. This tooth needs to be extracted. It's resorbed. It's just about to crumble. So socket shielding is done. Removing the crown first. I usually like to separate it from the adjacent teeth. Then I remove the crown fully so I have access. And then I start to adjust the shield. I decided intentionally at the beginning to leave it at the gingival margin, slightly below, not to bring it all down to bone level. So this is a mistake. So try to follow, don't take this example from me. Try to follow what's recommended from a trusted source that says, keep it at bone level. There's a reason for that, because if you don't, the soft tissues will have, especially in delayed cases, the soft tissues will have problems to heal and close up, and my whole graft got infected. And in order to repair this, I had to go back in there, anesthetize, remove the graft, adjust the shield again, wait for soft tissue coverage, wait for it to close, then go back in there. Obviously, my graft did not work. I still had bone for an implant, and I got a reasonable result. But my conclusion is keep the bone and the shield at the same level. Okay, so here's the outcome. And again, a good outcome. We are losing the papilla. Look at the papilla before and look at the papilla after. And of course, the patient is ecstatic to have a tooth and happy with the result. But the papilla that was nice and pointy at the beginning is no longer there. All right. How about removing the palatal aspect? Palatal aspect, I told you before, I had some challenges myself, and very often it fractured on me. It had some issues. So I did the best that I could, but then going back into studying the CT scan prior to placement, I noticed something interesting. I noticed that I kept part of the palatal root structure there. Here's the report card. Here's the report of how you performed. I could not see it at the time of the procedure. I could not see it at the time where I did the socket shield and grafted it and sutured and all that and waited. It's so dense. The root structure is dense. Sometimes not necessarily ankylosed, but sometimes you will not notice it. You notice it later. So I call it a socket ring. And I was contemplating, what should I do? Should I go back there and remove it? I decided to place the implant through it. And it was not an issue. Another problem is shield loosening. So if you prepare your shield, if you loosen it, it will cause an infection. Like a mobile tooth that has no more defense mechanism, it's not viable. And here's one of the examples. I did a socket shield. I planned it. It started to loosen up on me after the implant placement. As it loosened up, a secondary infection happened, which led to the loss of the implant. So I don't want you to feel that socket shielding is a panacea, is something that is now a magic bullet, a golden solution, whatever you may call it. You're going to have some problems like myself, and I'm sharing just a few of them. It's part of your growth. And I also don't want you to feel that this is something that holds you back. The successful people, successful dentists, is not about skills. It's not about letters after your name or having accolades and things like that. The successful people look at things differently. They have a different mindset. They have different habits, and they don't let disasters and infections and failures affect them. They have a different meaning. What was here for me, and not that I'm saying that I have all the best habits in the world, but what this taught me is, stop. Not all of your cases are going to be successful. You got to have some good ways to communicate with your patients, and you have to have some good solutions, because a failure in the aesthetic zone, we all know, is a big problem. So I shared with you different types of problems and different types of maybe thought processes when it comes to preserving the buccal plate. Now I'm going to just combine them a little bit together and share with you one more case where I saw this as a big challenge. Why? Because the patient came in with a root fracture that was more palatal. So we lost the palatal bone. And I mentioned before, the palatal bone it's our last hope. It's our last hope. We're going to lose the buccal bone, because the buccal plate, because of biology. The palatal bone usually stays, but if you already lost the palatal bone, that makes those procedures even more challenging. So when you have similar situations, don't jump in. Don't just go in there, let's do it, extract and do all the magic. No, don't. Just take a step back, analyze the scan, see where the bone is, talk to your patients, tell them, listen, your situation is quite severe. I have the skills and I have the expertise to treat that, but it has nothing to do with me. That's biology. So we'll have to take it step by step. And the first step is to remove the tooth in the least traumatic way, and we'll have to build up the bone and build up the tissue as best as we can. So I'm going to share with you what I did in this case. I recommended a socket shield. We took off the crown maybe a little bit too aggressively, but crown is off. I followed the socket shield protocol with those 3 steps: splitting the root, removing the palatal aspect of the root, and then adjusting the buccal part of the shield. But then I felt I wanted to augment the palatal bone. Augmenting palatal bone is not a predictable thing, not in my world. It's not as predictable as augmenting the buccal bone surgically. So I felt I could use anything that I can, use in in the patient's mouth. And that's why I decided to use a rotated palatal flap. And how do we do it? We reflect the full thickness flap on the corresponding side. Then we split it from distal to mesial. And as we get closer to the lateral, actually slightly closer to actually the central, we're going to flip it over. Okay, not choke it and rotate it, but just turn it over the socket. So if I place bone in the socket plus some bone to reconstruct the palatal bone, now I have a strong layer of vascularity that constantly nourishes the socket and nourishes the bone on the palate, plus augmenting, of course, the buccal, because we are taking this rotated palatal flap and we are tucking it in onto the buccal and stabilizing it and letting it heal. I'm a big proponent of waiting and giving it some time. We are always in a rush to do things fast and satisfy our patients, maybe satisfy us to get things done immediately. It's not always the best choice. These things need their time to mature and heal and consolidate. And only when they're ready, then you can go back and you can assess it with a scan. And again, our socket shield is there. And I did a decent job preserving it. The palatal bone is there. It's not corticated. Maybe it'll become corticated later on, but I know I have a good foundation of bone, and I can now plan my implant, and I can plan it in the right position so the implant can have a good restorative outcome. Will we get the papilla? It'll probably be compromised, but we have a good chance to have a success rate. Now, is socket shielding and palatal flaps, is that the standard of care? No, it's a tool that you have that is relatively simple. If you go through your roadmap of skills, you can use those techniques to get a better outcome. And I want you to be aware of it. So I showed you a lot of things in socket shielding and palatal rolls and things that hopefully made you think a little bit. My recommendation always, if you feel a little bit confused, go back, think about basics. The most basic procedure that one can utilize in practice is a soft tissue graft, like a free gingival graft. How much root coverage are we getting with it? How much, do we use perio dressing? Do we suture the palate? There are a lot of questions that I'm happy to discuss with Omid after the presentation. A lot of concerns patients have. When do you use free gingival graft? When do you use connective tissue graft? When is it contraindicated? Do you use PRF, periacryl? Can you treat mobile teeth? These are great questions. I personally created a program called the Masters of Soft Tissue. It's a program that is meant to teach you the basics of soft tissue grafting in a very simple and predictable way. I teach procedures that are simple to do. They're lucrative. They have a low overhead. They don't produce any aerosols. We know aerosols are now bad. And this is a program that is now available on my platform. It's a 1 full year mentorship that teaches you the pillars and the practical knowledge to do simple, safe, low overhead, lucrative soft tissue procedures in your practice. And in this program, I teach from the basic to the advanced. We have it in 4 modules. We're actually starting today. We talk about Module 1, soft tissue quality. Module 2, how to cover roots in the aesthetic zone, 1 or 2 teeth. Then we move on to the full arch and the full mouth grafting. And then we talk about preparation for aesthetic cases, crown lengthening, balancing the tissue, creating symmetry, and making sure that your restorative case restoratively, but also have great tissue around them. The course is delivered through online coaching, webinars, video tutorials. I show the surgeries that I've done in my practice in this training, and registration is actually closing today, and it's called Masters of Soft Tissue. So thank you for the opportunity to present to you, and I'm happy to entertain questions and talk to my friend Omid here, and it was a privilege.
Thank you so much, Ziv. Really enjoyed your presentation. I'm pretty sure all the audience have the same feeling as me. And I really wanted to mention your program and this surgical master group. So for those interested, I really recommend you all to join Ziv on his Facebook group, Surgical Masters, and lots of great information you can find regarding his courses. And also you can subscribe and be always up to date with all he's doing and very informative materials that he presents to all of us. So thank you again, Ziv, for this uh, beautiful presentation. And now it's time for having a little discussion on the topic. So one of the things that I wanted to mention was regarding preparing the recipient side for free gingival grafts. As you mentioned in the first case, you showed that to go perpendicular to the mucogingival junction and prepare the bed and put the free gingival graft in the area. So my question is this: if you don't have enough attached gingiva or keratinized tissue, what if to place our graft exactly flush with the tooth and not going at the mucogingival junction to minimize the discoloration or color change from two areas? And what I considered in your case was that when you put the before and after, in the pre-op case, your incision was to the mucogingival junction, but in the post-op case, the free gingival graft was completely level with the bone, level with the tooth. So I wanted to know, did you do the de-epithelialization at the later stage and then fix your graft, or was it something like creeping, can I say, or something changed there? So my first question was that on that case.
Excellent. Just so we have it in front of us, because this is such a great observation. And you know what I like to teach, and I know you will resonate with it, is teaching not just surgical technique, but teaching how to look at things and how to think about things. And that's what you just asked. You know, you notice that the incision was actually much lower. So the key here, in order to get this result, is to de-epithelialize. So I did my incision lower than the free gingival margin, where I felt the mucogingival junction was. But then I went back and I de-epithelialized whatever was there.
Mm-hmm.
And as I placed my graft, and I placed it wide enough laterally and enough apically so it retained its blood supply, this is what explains it. The challenge that a lot of doctors have, including myself, is sometimes you can't even identify the mucogingival junction. Sometimes the mucosa is all the way to the free gingival margin. Where do you make the incision? Because we don't want to make the situation worse. So I very often make a submarginal incision, meaning below the margin, where I think the mucogingival junction is. Apically position the flap in split thickness, suture it, and then if I can, I try to de-epithelialize. The thing is, how do you de-epithelialize something that is so thin? If you de-epithelialize it, it's gone. Does that answer your question, Omid? Or do you want me to tweak it a little bit more?
No. Actually, I just wanted to have that point that we should definitely do the de-epithelialization, because also if we don't do that, usually we see the color change in the area, and it's very obvious for the patient. But when we do the de-epithelialization, then it can be more less, comparable to the adjacent areas. So other thing in free gingival grafts, do you prefer to suture the apical part of the bed preparation or leave it? Or do you find any difficulties if you leave it without suture?
Excellent. So I only suture the coronal part of the graft for a very simple reason. Even if I stabilize the mucosa to the periosteum underneath, and I did a good job in that, if I now suture the graft to an apical component, whether it's the periosteum or the mucosa, there is a potential that you'll apply apical forces on the graft. And that's exactly what you don't want. So in my experience, what works the best is only suturing it coronally, maybe a little bit laterally, like you see here, and then using periacryl. When you use periacryl, which is technically cyanoacrylate, a couple of drops, rinse it out with some saline, this graft is so tight and glued to the recipient side, it's not going anywhere.
What about?
So you don't need it. You don't need the ones. And there's another modification. Some like to place X sutures,
Yeah.
and go around the tooth and just round it down. That's totally fine. It's one of the options. I don't, but it's totally fine to do that.
But what about suturing the mucosa? Not the graft itself, but the apical part of the mucosa to the periosteum, because some surgeons doesn't do the suturing.
Yeah, it is sutured.
So you prefer to do the suturing?
Yeah, it is sutured. The mucosa has to be sutured apically.
Mm-hmm. And with
gut sutures. So I do suture it apically.
And what's your experience with using tags and pins for securing the pharyngeal graft instead of sutures?
That's a great idea. I never used it. What's your experience? I never used it. I think it's actually an interesting idea.
I have to tell you, I did it for I'm doing it for about 1.5 years now, and it made it very fast and very simple. You need to have only 2 tags or pins, or in large cases maybe only 3, especially when you are doing the pharyngeal graft in the posterior mandible, when you've lost lots of vestibular depth. So it's very fast, it's very easy, and in about a week, those tags are loose and the patient doesn't feel anything. So just wanted to know if you have also experience with it. If not, try it, because it's very, very faster comparing to the sutures, especially in the areas that you don't have enough access for doing the suturing all around. And one of the other things that
thank you. This is Omid. This is why I learn. This is why I teach, because I want to learn. So I'd love to know how you do it. So that's great. Thank you.
Welcome, my friend. And what about the dressings? Me personally, really don't use dressings. Maybe only in the palate, in the cases of large grafts. So to make sure that the patient during eating or drinking doesn't, feel any discomfort. But some practitioners like to put the dressing in the area that they're doing free gingival graft, the recipient side, or doing the root coverage procedures. So I want to know your thoughts on that, because you mentioned periacryl, so it's completely different than dressing, because it's a very tiny layer on top of the graft, so it won't put any pressure, patient can clean. But in the cases that dentists put dressing like Copac on top of the graft, at the time of suture removal, it's like a mess, the patient didn't have the chance to clean the area, and I believe it's not a good thing. So I just wanted to know your thoughts on that.
Okay, so let me answer right off the bat. I don't use dressing. I use dressing only on a salad. Okay, so let me tell you my opinion about dressing. When you started talking about it, when the patient comes in for suture removal, or for, let's say, the post-op appointment number 1, and you remove the dressing, at the same time when you remove the dressing, you have to open the window, because it smells so bad. Why does it smell so bad? Because there's bacteria underneath the dressing and there's no salivary flow. That is not a good thing. Is it detrimental? No. There's a lot of, the mouth is contaminated. It's not necessary to use dressing. What I like to use is periacryl, which is not a dressing, but then I take PRF membranes, and I use periacryl, and I glue them on top of the graft, and then I take a second one. So that is my dressing. It's a biologic dressing, and it protects. But certainly you don't need to use dressing at all.
Yeah, I agree with you. And what about the cases that you presented with the socket shield? I noticed that one or two of your cases had external root resorption, if I'm right. I think one of them was central with the external roots. I think the case that when you wanted the dissection mesiodistally, you said that you changed the scenario and went with the delayed approach, or went with the implant placement without socket shield. So I want to know that the external root resorption, is it a good candidate for socket shield, or there is a risk for having the dehiscence in the area, so maybe not a good candidate? What's your thought on that?
Okay, great question. So root resorption, depending where is the root resorbed.
Mm-hmm.
If it's resorbed on the palatal aspect, I don't think it's an issue.
Yeah.
If it's resorbed even mesiodistal, and you, through the sectioning and the modification of the shield, you get rid of the resorptive part, I did not see an issue. However, what you may be asking, or maybe some people watching this are asking, so you did your socket shield on root resorption. Who says the root resorption is not going to come back? Mm-hmm. And I don't have an answer for that. I feel it's like a root resorption repair. Sometimes we do an open flap repair. We open the tissue, clean out the resorption, restore with gel restore, close it up.
Yeah.
Sometimes it comes back. So I don't think it's a contraindication as long as you can remove the resorptive part as part of the process.
Yeah, agree with you. And one more thing, in the cases that you want to decide to go whether with the socket shield or not, sometimes the level of the buccal and palatal bone is different due to maybe previous periodontal problems the patient had, or maybe the dehiscence with no pathology reasons from years ago. So you have differences in the buccal and the palatal. And from the aesthetic standpoint, especially in the aesthetic zone, if we go even with the socket shield, we are forced to place our implants according to the buccal plate, not the palatal. So in those cases, if you decide to go with the socket shield, do you think is it possible to do GBR and increase the level of the bone on top of the shield or not? Imagine you have a case, the buccal bone is here.
That's a great question.
The palatal bone is here, and the shield is here for preserving this piece of bone, but you want to place your implant regarding the palatal wall, not the buccal wall, because it will be too deep. So do you think, is it possible to build up the bone here and leave the shield in the middle?
Yeah, I think it's possible. I don't have a whole lot of experience. Okay, in full transparency, I don't have a whole lot of experience. So it is possible because the socket shield it can only help to preserve some of the structure. And it's not a coincidence, we call it a root membrane. But my recommendation is don't place your implant immediately. Build up the bone because there are a couple of unknown factors in there. And one more thing that is very important that you brought up right now, if the patient starts off in the aesthetic zone with recession and starts off with, a big dehiscence, fenestration is not an issue so much, but dehiscence, the whole thing is gone.
Yeah.
Or part of it is gone. Then you want to build it up first, because what you see is what you get. If you do an immediate, and again, I'm not saying it's not possible. I just, my mission is to teach doctors to be safe. I don't want anybody to have a patient that is upset, is going to sue them, and the practice is going to go down. That's not a good thing. I want you to be successful and your patients be happy. Okay, simple. How do we do it? By minimizing risks, mitigating risks. So if you look at my own practice, I don't do, maybe because where I practice, but I don't do like crazy augmentations, building up like mountains of bone. It's not so much my niche, but I'm also finding ways to do things in the most conservative way. And this is how I teach. So if you have a patient that has gingival margin of one tooth is here, the other one is here, don't place an immediate implant. Try to get them as close as you can first. See what you got, and only then go in. Whether it's a socket shield or GBR or mesh or a bone plates, Curie technique, whatever is applicable and whatever you feel comfortable doing.
Great.
So yeah, so the discrepancy is not a good thing. Don't compromise the position because of where the bone is. Try to build it up first.
Exactly. And one final question, because your topic was very amazing, very interesting, and I'm pretty sure we can talk about it like a whole day. But my final question
Sure.
is, what do you think about the minimum height of the shield? We have different recommendations. All of them seems to be acceptable, but imagine you wanna have a shield height. And as you said, regarding the recommendations, we should remove the apex. So that's the key. But speaking of the height of the shield, what's your recommendation? Do you prefer shorter height, like Marcus Herzeler really usually recommends not long shields are really recommended, and we can have it shorter. But some people mention like 6 to 8 millimeters. Some people mention something different. So we have different ideas. And I believe that it's not a necessity to the technique as long as the shield is not mobile. But just wanted to know your idea about it.
Okay, thank you for the question. And I was never asked this question, so I appreciate it. But I thought about this question in my own mind. How should I put it? We don't have that much control as we would like it. We would like to have. We don't have that much control as much as we would like to have. So even if I gave you an answer, by the way, we don't know. That's the bottom line. We don't know what's good, what's bad. We don't know. We know we need to get rid of the apex.
Yeah.
We know we want to keep the corona part of the shield, but we don't know scientifically. So let's forget about the academia. But let's say my philosophy goes by expert X, and it's the shield should be full length or should be half length. I don't think anybody right now has 100% the hand skills to control it, because even in my own hands, and I've done a lot of socket shields documented in video, and you see I document pretty well. Even in my hands, I sometimes mess it up. My burr goes at the apical part of the burr, it goes through the buccal plate sometimes, and I thin it out too much. Sometimes I leave it too far. Why? Because I have a limitation of access and visibility. So I think, and this is what I don't want anybody to get confused, because your question was excellent. If you want to focus on one thing, make sure that you have at least 4 or 5 millimeters of the coronal part of the shield. That's the most important thing. That's what I want everybody to remember. If you got it, I don't think it's going to make or break the case. I even, I follow, the people that you follow, that you interviewed, they say you got to remove the apex because there's some pathology there. Yes, but sometimes you have no control if you left a little root tip, or a little, even lesion. I'm not going to go in there and do apicals. I'm not going to go open a flap and start cleaning the apical part with an apicoectomy. So keep the coronal part of the shield at least 4 or 5 millimeters. If it's a little bit longer, I don't think it's going to make a difference. Thank you for the question. This was excellent.
Okay. And when you mentioned about the apex, I just wanted to share again something with you. Actually, it's been published. I think some people called it like a T-bolt. Like some people, introduced it during the presentation of the socket shield over the past years. But I had some cases in my practice that the tooth was completely ankylotic. And during the surgery, but there was no apical pathology. But the tooth, with some reasons like caries or fracture, needed to be extracted. So I tried to extract the tooth atraumatically, and I found it that it's not possible. And I changed the scenario. I drilled through the root canal and with the implant drills, like the first scenarios introduced for socket shield. And then with all the other principles of the socket shield, reducing it to the bone level and etc., having the bevel for providing prosthetic space, I placed the implant inside the root. I mean, I prepared the root circumferentially for implant placement with the diameter that I wanted, and I placed my implants. And believe it or not, those cases have like 1 to 1.5 year old. They're just done about 1.5 years ago, and everything so far is stable. So one of the articles that you shared from Danny Baumer and Marcus Hauser doing the histology and showed that even if the tooth is in contact with the shield, then no problem will happen. Maybe it's possible. So it was just many cases. I don't have that much documented in long term, but I think it can work if you are forced to do that. Not as a recommendation, but if you're forced to do that, maybe it works.
No doubt about it. No doubt about it. Nothing is guaranteed. There's only one thing in life that is guaranteed. We know what that is.
Yeah.
So I think what you did, and I think this is a great message for the doctors that are watching this. Don't be dogmatic and don't be too rigid. Even if you're a surgeon, even if you are a periodontist or you're very good with extractions, if the tooth is ankylosed, if you're going to try and remove all of it, you're going to ruin all the bone and maybe the adjacent teeth, and you're going to create so much trauma that it's going to be bye-bye to an implant. So what you show is, okay, I have to switch my mind in the middle of the surgery and say, okay, this tooth is not going to come out. It's not like Benex extractor and you become like so slick in extracting teeth. I got to change switch my mind. I'm going to now reach for the implant drills, and I'm going to go with the implant drills. And I've done this before. To be honest, in my heart, I was a little bit nervous about it. I wasn't like, oh, no big deal. I was a little bit nervous about it, but what's the alternative? I'm not going to go in there and try to dig. I did this in the past, by the way. When I learned how to extract teeth, if I left a little root tip, I could not sleep. Now we know if you're going to go for this root tip, you can damage the patient. You can go into their sinuses, you can go into their nose, you can damage another root. So I think what you're teaching us here, and again, thank you for all those great questions. What you're teaching us, me, and the community is always be open based on the circumstances. This is the key for a great surgeon. You're driving on the freeway, whether you're in Los Angeles or Iran, and you need to go somewhere. Mm-hmm. You know what? If a car is going to go in front of you, you're going to move. You're going to just stay away. You're not going to keep driving because you're going to get in an accident. You have to be like water. You have to be fluid. Exactly. And that's great advice.
Thanks, my friend. Ziv, I again truly appreciate your time, your care, your support, and that you accepted this invitation. Really enjoyed talking with you and listening to you, and really looking forward to see you very soon, whether United States or Iran or anywhere else in the world. But thank you again. I hope all the audience also have enjoyed your presentation. I'm pretty sure they did.
Thank you so much. First of all, I would like to thank you for the invitation. I followed your work for many, many years. Your commitment to teach and give others knowledge is commendable. And what you organized in Iran, a symposium on complications, is amazing, because a lot of surgeons or doctors like to show their successes. We have more complications than other people who even have regular cases. Why? Because we do this a lot. And we got to show dentists that there is a way to overcome those complications. Don't lose the bigger vision of yourself because you had 1 or 2 complications. Exactly. You're not a bad doctor. This is part of our journey. And I really enjoyed our conversation. I hope to come to Iran one day. Right now is a hard time. So everybody watching this, this broadcast, I hope you're safe and healthy and your family. Dentistry is not going away. People will have dental problems. It's only when this corona outbreak is under control, we'll go back to our practices. We'll practice a little bit differently, but we'll go back. And again, thank you for, the great time we had. I enjoyed it, and I look forward to meeting you.
Sure. Thanks, my friend. Take care.
Okay. Take care. All the best.
You too.
Be well.
Safe. Thank you.